Good afternoon, dear colleagues. Thank you for the opportunity to present our work. Today, I would like to share our experience in the surgical management of full-thickness macular holes without gas or air tamponade. Currently, the gold standard for macular hole surgery is pars plana vitrectomy followed by gas-air tamponade. At the same time, many alternative techniques have been proposed, including inverted ILM flap methods, autologous plasma application, partial or complete ILM preservation, combinations of these techniques, and various endotamponade options. Endotamponade options include gas-air mixtures, silicone oil usually reserved for giant macular holes, or retinal autotransplantation techniques, and in selected cases on BSS. BSS tamponade has several advantages. There is no need for face down positioning, visual recovery is faster, the risk of transient ocular hypertension is lower, early postoperative OCT evolution is possible, patients can travel by air. Today, two main types of autologous plasma are used in macular hole surgery: autologous conditioned plasma or ACP and platelet-rich plasma or PRP. The principal difference between them lies in their cellular and physical properties. ACP contains fewer platelets and leukocytes and tends to coagulate rapidly, forming a dense biological membrane. In practice, surgeons often use whichever plasma is available, and moreover, surgeons often prepare ACP because it appears more stable. However, when ACP is used in an aqueous environment, specifically with BSS tamponade, it becomes clear that despite of its biological advantages, ACP still requires some external compression or tamponading force to remain effective. Excellent results with ACP can be achieved when it is mechanically pressed intraoperatively under PFCL and supported by gas tamponade, as you see on the left picture. In contrast, under BSS tamponade, ACP is unable to penetrate transiently due to its biophysical properties. PRP, on the other hand, is more fluid and can easily penetrate tissue, making it ideal for filling the macular hole. As a result, ACP doesn't form a plaque within the hole but instead creates membrane on the retinal surface. Here you can see the early postoperative appearance. These are two different patients, but in all cases where ACP alone was used, we observed very similar OCT findings. Referring to the study by Krupina, this phenomenon may be explained by difference in the prothrombin index measured by the quick method. ACP has different coagulation properties, coagulates faster and forms a membrane before it can penetrate the retinal layers and fill the retinal diastasis. Based on these observations, we developed a technique of binary application of autologous plasma. After ILM peeling, PRP is applied first to fill the macular hole. After a short exposure, no longer than 1 minute, ACP is applied on top, forming a biological membrane. In this way, a combined PRP plus ACP complex is created, providing a more stable and reliable biological contrast. Now I would like to present a clinical case. A patient presented with a pseudophakic eye and a full thickness macular hole. Preoperative visual acuity was 0.2 and the macular hole was 308 micrometers in diameter. So as you can see, we are doing central vitrectomy, so after then staining ILM, and now we are doing peeling ILM. Now we injected PRP, which fills the macular hole. Then we injected ACP, which applied to create a stabilizing membrane. The surgery is completed using the BSS only. Postoperative positioning is extremely important. The patient is instructed to remain strictly in supine position, not with the head elevated, for approximately 2 to 3 hours. This is necessary because upright or semi-upright positioning may cause displacement of the PRP plus ACP complex during early postoperative transport. On this slide, the ACP membrane is clearly visualized. On the CT, ACP appears more hyperreflective, whereas the PRP plaque is less hyperreflective during the first postoperative day. Here is another clinical example with a smaller macular hole, 197 micrometers in diameter. On postoperative day 1, we observed closure of the inner retinal layers with a residual diastasis of the outer layers. After 1 week, this diastasis completely resolves. ACP plasma is clearly visible on OCT, confirming its stabilizing role. In conclusion, this technique appears to be effective and can be used in surgical practice. However, further studies are required to evaluate the long-term anatomical and functional outcomes of this method in the extended postoperative period. Thank you for your attention.